Welcome, everybody. I hope you're enjoying networking, reconnecting, and mingling with new colleagues in here. I've hoped you enjoyed lunch, coffee. By now, I think the Geneva Health Forum has honed the art of virtual and hybrid events. But I've got to say, it's so great to be in person again, having that social and human connection again. I'm sure many people here feel the same. Now, if you haven't had the opportunity yet to go to the first floor upstairs to look at the innovation booths, please do so because you have the opportunity to decide which one is your favorite, which one's the best, and then you can vote following the link that you received today in your email inbox. Now, the next panel will be about data sharing in the time of COVID-19. What has worked and what is still missing? Now, allow me to introduce you to our next set of panelists. Please join me at welcoming Rob Terry from TDR, the Special Program for Research and Training in Tropical Diseases. Naomi Wadira from Mahidol Oxford Research Unit Data Sharing Working Group, COVID-19 Clinical Research Coalition. We have Philippe Guérin from the Infectious Diseases Data Observatory at the University of Oxford. Nathalie Strub from the Drugs for Neglected Diseases Initiative. And allow me to welcome our moderator, of course, François Chapuis from the Geneva University Hospital. Now, I may come back in the last 5 minutes as a heads up that time is running out, but in the meantime, enjoy the session.
Okay, thank you very much. Thank you and welcome everyone for this last session of the day. I work in a few kilometers away in the Geneva University Hospital, and last year they updated the template of our curriculum vitae, and they added a subsection called Contribution to Open Science. And in here, of course, the first things that comes to mind is publishing in open access journals, which is now, the uptake is really good, especially now we have funding mechanism also to pay the high price to the editors. But there is this section that is promoted by Swiss universities, by the Swiss National Fund for Research, which is data sharing. And this section is empty in most of the files that are submitted to us for academic promotion. So data sharing in the time of COVID is what works and what we need, what doesn't work yet, is the thematic of the session. And I turn myself to those who actually know what they're talking about, unlike me, when it comes to data sharing. And we will divide this session in 3 sections. First, each of the panelists will have a one-man or one-woman show that will last up to 5 minutes. Then I have a series of questions for them. And then we should have 10 to 15 minutes at the end, at least, where it will be open to the audience to either ask questions or relate about their experience, etc. So let's come first to you, Rob, from the TDR WHO. What do you have to tell us about data sharing?
Okay, thank you, and welcome everybody. So we talk a lot about data sharing, and I think the first thing that we need to think about is not the sharing so much, but the reuse. It's the value of what's in data that can be reused, repurposed to create new knowledge, to provide insights into guidelines, and even lead towards better and improved treatments. So always bear in mind, when we're talking about sharing data, we're talking about using data, making sure that the work that's been done to collect data, because it's quite arduous and it can be quite costly, we're going to get the maximum benefit out of those data. And this is really important. If we think back to the early stages of the COVID-19 outbreak, when we were really working in the dark, the earliest guidelines that WHO produced, certainly for therapeutics and others, 40%, more than 40% of the references in those guidelines were preprints. 30% of the references were data shared directly with WHO, and less than 25% were the standard, what I would call the old-fashioned way of publishing and peer review. So it's really important that we have access to data and we can use it and reuse it. And so one of the things that I did want to highlight today, WHO, as part of the working group, has just published a new guide. It's a guide for its own staff and for those researchers that it works with. It's called Sharing and Reuse of Health-Related Data for Research Purposes. It's freely available. It's in the WHO repository. It's called IRIS. And I mention it because it meant that we've spent a lot of time in recent years trying to work out what is the framework that we need to put in place so that we can encourage people to share data and we can maximize the benefit that comes out of the reuse of those data. And I think the first thing that we came to was something like we call the 3 E's. 3 E's, the principles of data sharing. And that is, however we do this, we must make sure that we're doing things in an efficient way. We absolutely have to do things in an ethical way. And something that's often forgotten, and that is that we must be equitable about sharing. And I'm sure we'll hear more about that from the other panelists. And that is that data, when it's shared, doesn't disadvantage those who are sharing the data. And this is typically, we find, say, researchers from low and middle-income countries who often feel that they're being exploited. Their data is exported and the benefit and the gravitas and everything goes to others. So we need to bear those principles in mind. And then we start to get into the technical aspects of how we share data. We need to make sure that data sharing is what's called fair, which means that it's findable, that it's interoperable, that we can actually combine data sets and use them together. It's accessible, so it comes under a license which allows us to use and reuse and repurpose. And it's reusable in that way, that it has that. So these are the sort of fair principles. There's a lot of issues that come with data sharing, and they tend to be political, and they tend to be ethical and technical and legal and social. And we have solutions for many of those. So what we're really now trying to do is create a culture where sharing is the norm, and we expect it to happen because we can see that the benefits that we're gaining are so much better when the data is available and able for reuse than locked away in a drawer or, in these days, a hard drive. Thanks.
Thank you very much. Thank you. And you, Naomi, data sharing.
Yes, so I'm going to give a perspective of data sharing, the challenges that are there, and in particular, those which affect health research data. And in the recent past, we've seen a lot of policies coming up from funders, from journals, and even from research institutions promoting sharing of data. But one issue that's a main challenge with health data is the concerns over privacy and confidentiality of the data. And in the recent past, there's been an emergence of new data protection laws or refinement of existing laws, such as GDPR in the European Union. We've got POPI in South Africa, PIPL in China, and many more. And the aim of these regulations really is to ensure responsible collection and use of the data, but at the same time to also outline the rights of the data subjects with regard to how their data is used. Now, most of us, perhaps all of us, have seen a notification on a web page asking if you'd like to accept some cookies or all cookies. And if you are like me, liking cookies, maybe you accept all the cookies. But what essentially we're doing is allowing the owner of that website to capture our data, which could be your name, your telephone number, your contact details, and even activity that you're involved in beyond what you're currently doing. Now, the same regulation that governs collection and use of that critical data is the same regulation that governs use of public health data, which could be used to inform interventions to promote health of the general public, but is not potentially as disclosive as this other kind of information. So there's need there, first, to not have blanket privacy regulation, but to have regulation that addresses the actual risks of disclosure within data. Now, the other thing is, what are the main concerns for participants and data subjects about how their data is used? Would a patient with severe malaria be more concerned about the possibility of their data being used to generate new treatment, or someone finding out perhaps what they're ailing from? I would say the former. So then there's a need to engage with the public with regard to these data protection laws, what their needs are, and what actually they do consider as a huge risk. We talk about data anonymization and de-identification as possible solutions to address confidentiality of the data. But what these techniques do actually is to minimize the scientific utility of the data, because what you do when anonymizing, you want to remove parameters which could potentially identify the person. But the complexity of data reuse is we actually do not know what in the future these data sets could be used for. So if you'd like to use a data sets, for instance, to work out an optimal dosing strategy for young children, you do need to know how old they are, because the profile of a 20-day-old child is different from a 4-year-old child. You need to know what diagnosis they presented with, and you need to know their outcomes. But these are the very parameters which would be removed if you're de-identifying data. So then you wonder, how can we promote data sharing, but at the same time retaining utility of the data? Now, we have governance mechanisms to address this, such as data access committees, which consider proposals for use of data and then ensure there is appropriate data use agreements to that. But this do add an extra layer of bureaucracy and administrative burden on the data users. So there's a need then to streamline that process. So in conclusion, I think we need to have more engagement with the public to understand their concerns and what they perceive as risks of data sharing and reuse, and then use that information to then rationalize data protection laws so that, in effect, data protection laws are not a stumbling block to data sharing. Thank you.
Thank you. Thank you very much for this interesting comment. Philippe, anything to add on your side? Probably yes, otherwise you would not be here.
I'll try to add something. So good afternoon, everyone. So I was asked to tell you a good story and potentially a not so good story about data sharing in the context of COVID. And so the good story came from an alignment of stars. So of course, in the context of an emerging infection, you don't know what's going to happen. And so imagining that we could plan that in advance is a bit of a dream. But in the context of COVID, we were closely working with ISARIC before, which stands for the International Severe Acute Respiratory and Emerging Infection Consortium, which is a group of people mostly working in hospital who had been working on developing a template case report form, which was potentially to be used in the context of an emerging infection. So they had already an existing network around the world of hospitals ready to use this form. So very rapidly, they adapted the form and started collecting in hospital data in the context of COVID. And on the other side, we had our platform, the Infectious Disease Data Observatory, IDO, which was ready to take and receive the data. So we have a framework to receive in a secure way the data. We have a way of harmonizing this data, because despite the fact that we were disseminating a standard, people were doing slightly different things. So we had to put a lot of effort into what we call curation or harmonization of data. And then we were able to potentially reshare the data for reuse, as Rob mentioned, later on. And what we have achieved to date is essentially assembling 800,000 individual patient data from 64 countries. And this has resulted to date into 56 individual patient data meta-analyses, which are either published or on the way to be published. So that was the good news. So it does show that it was possible with a consortium and strategic partnership to share data fairly rapidly and collect and share this data for reuse. Now, it worked very well for this kind of data, which was longitudinal data, which helped a lot in describing the natural history of the disease. It helped a lot also of having this existing partnership from before, and a colleague of mine who the credit should come in leading this work, Laura Merson. So that was the good news. The not so good news will be on the clinical trial data. So one thing that we have done at IDO was trying to look and mine all the studies which are registered in the context of COVID. So as of April 2022, there have been 12,766 studies being registered in clinical trial registry around the world. If we focus on active pharmaceutical ingredients, so therapeutics, drugs for the treatment of COVID, there is more than 4,000 studies which are registered. Some are completed, ongoing, or will eventually never be done, but 4,000 have been registered, testing 318 different active pharmaceutical ingredients. So huge amount of research, so great. So where is the problem? Well, the problem stands in the fact that if we look at the number of times investigators have been repeating the same experiment, it has been quite outstanding. So we had 420 plus hydroxychloroquine or chloroquine clinical trial done in the world, more than 120 on azithromycin, more than 100 on dexamethasone, about 130 on ivermectin. And a lot of these trials were relatively small sample size with various methodology, and many of them actually giving slightly different outcome. So that's the reality. So now the dream would have been, okay, we've got all these data somewhere, can we assemble them? Well, there were no mechanism to either stimulate or force or engage the investigator to do that, and the data are just coming in a very, very late pace. Meaning that actually all these studies have not resulted in a lot of the recommendation, which is the current treatment guidelines from WHO. And only the very large clinical trials, and I will name just for example, Solidarity, Discovery, Recovery, have been the trials which have generated the kind of data which has allowed to draw conclusion. So lots of data there, but not being shared, while it's a very clear demonstration that if these data were to be shared, we would have had a much better understanding on the potential therapeutic of certain drugs, and we have missed that opportunity. We'll come back probably to what will be the next step for the next pandemic, and hopefully we will be better prepared. But there is clearly, in my opinion, something that we need to be reminded. We can't organize things in the time of a crisis. Things have to be organized and set up in time of peace. And without this organization in place, we will eventually fail again, as we did for Ebola, as we did for COVID. We will fail again to have an environment where we can share and amalgamate the data of value for a pandemic like COVID. Thank you.
Thank you, Philippe. I'm really learning a lot. To end this first part of the session, I turn to Nathalie. Nathalie, if I would quote Ali G, he would probably say something like data sharing. What's the vibes?
Thank you, François. So maybe as an introduction, I would say that during clinical research, data sharing covers a lot of things and different things. It does cover sharing of data, but it also covers sharing of protocols, sharing of CRFs, sharing of SOPs. In fact, in 2020, some of us here launched a coalition, very worried that during a pandemic, it would be crucial that we share everything, every knowledge we have developed collectively so that others would benefit from it, and we save time, we avoid duplication, etc. And this is how our clinical research, COVID-19 Clinical Research Coalition was born. And I have to say first that one of the simple things we asked for was sharing protocols. We had to struggle quite a bit for that. So it's not good news, I have to say. But maybe today what we would like to speak more about is individual data sharing, which means the individual patient data that are collected during clinical research. And some say that, publicly funded research data could be considered as a public good, therefore they should be made openly available with as minimal restriction as possible, complying with, of course, with the governing and ethical rules in a timely and responsible manner. So what I'd like to do now is to illustrate what we have learned from our experience at the NDI, working on NTDs and a little bit on COVID. And first, develop what can be the value of sharing data, and then a few points to consider. So the value that we see, and we haven't mentioned this, but you've mentioned this a bit, Naomi, but I think it's building trust. Building trust among researchers, but also building trust with the community. And how much do we know that this has been a problem for hydroxychloroquine? If we had had access to the data, I mean, let's not open this again, but that was really terrible. But trust between researchers as well. And it also means that we share data even if they are negative, and that's an obligation that we have, and we do this timely. The other value is reinforcing data coherence. I think Philippe mentioned the example of the hydroxychloroquine or azithromycin or ivermectin clinical trials, which were replicated time after time after time, not well-powered, underpowered, still interesting studies when they were of good quality. And if we had had an instrument to put the data together, even with the disparity of endpoints, of doses, of treatment duration, we could have probably identified a signal, good or bad, earlier, which means we would have been able to switch maybe to other treatments more quickly, which is what we need in the time of a pandemic. We need to have information quickly. We need to make sense of the data as quickly as we can. So that is another value of data and sharing. Now, the very clear one is increasing the detection power by putting data together and allowing to do secondary research, which has a lot of value. I can give a few examples in the case of NTDs. In the case of NTDs, you have very little research. We have no guidelines, no research, data, very few. So we have to make sense of anything that we can grab as information, as solid information. In the case of sleeping sickness, we didn't know what was the expected reference efficacy for the treatment, the reference treatment next. So we did try to put, and we managed to put all these data together. This helps regulators to understand the value of another drug when it's developed. It gives you a benchmark. We also had to understand how do you make sense of clinical severity symptoms in relation with white blood count? You cannot do that without having more coherence by looking at all the data, putting them together and making a robust analysis. In the case of mycetoma, another hyper-neglected disease, we don't know what the efficacy is. There are a few data. In fact, IDO conducted an analysis of all the research that has been done on mycetoma. There is much more than we thought. But those data, if they are spread around and not put together, make no sense. So we have to put them together. We did our team working on cutaneous leishmaniasis identified by pulling all the data together that, in fact, when you look at the treatment duration or endpoint duration in a clinical trial, you can shorten this very significantly because we know now that despite independent of the treatment, efficacy can be seen in a reliable way after a shorter treatment observation than study observation than thought. That saves time, money, and there's more money for other research. So it's so much value here. The other information you could get by pulling data is for example, for COVID, is, what are the baseline characteristics that can help to predict severity progression? So, and this is even independent of a treatment. It's how do you understand prognostic factors. So you have to put things together because usually the studies, each study, individual study, doesn't have the power to do that except the really large one like Recovery, Discovery, and Solidarity. Of course, pooling data helps you to identify new safety signals, which is critical when you have some, studies of 200, 300, 500. It's by putting this together in a way that is harmonized and standardized. This is why we need a system to put this together that really helps. Other critical information you can get from pooling the data, meaning sharing data, is studying specific population response. So children before pregnant women, that's critical, making stratification by gender, by age, by immunosuppression status. All of this is really difficult to do if you don't have this system. So I think those are the key examples. Now, if we look at the points to consider and the solutions, so as Philippe said, I think we need to have pre-study agreements. When you start a study, there needs to be an agreement that you will share the data, meaning you have legal agreements in place, and it's not simple, but this needs to be done now as we speak. We need to understand the data protection rules, what exactly is meant by the GDPR, what it covers, what it doesn't cover. We need to have a format that allows to share data. When you have to curate the data, as IDO is doing for us on VL, on CL, on other diseases, it's sometimes too late. It takes a lot of time to put date of birth in the similar, or age. I would say age is easier, but there are some systematic parameters. If everybody agrees to put them in the same format, you save so much time, and then you can benefit from the value. Of course, we need to have good quality data. Note that some funders, I think we haven't mentioned this, but some funders, and of course journals, will only fund you if you comply with the data sharing rules. So one of the things that is critical is to understand the governance of how you share data. It's not just an open bar, it's under controlled conditions, but solid conditions, but still allowing data sharing. Understanding for the investigators what's in it for them is critical, and we can speak to this, but of course there is fear, and again, the experience in malaria, I think we can speak about, tells us that if you reassure the investigators that the value they have brought and the patients that have contributed to some research will not be lost, then, there can be some interest. The patients' informed consent are now really in a quite standard way mentioning that we need to, their data will be shared. And I think another thing which is critical is to have the funding, and that funders, those who do not ask for data sharing, also understand the cost that it entails to do data sharing, to curate and to maintain a database. And I'd like just to finish with one example, which is an interesting example in COVID, which is a prospective study between 4 studies that was looking at the anticoagulant protective effect. And so 4 studies that were separate studies prospectively decided to share their data to look at this aspect in COVID. That was very interesting. It's been published, and they managed to get a result, a significant result. So I think there's hope that we can contribute and work together on this.
Thank you, Nathalie, for this very rich comment. I'd like now to enter into the second chapter of this session. And to start with, I have one question to all of you, to each of you, to be more precise. What one thing would you like to change in order to improve the quality and volume of data sharing? Maybe we start back to you, Rob.
Yeah, it's a good question. I think, as we've heard, there are many, many things that need to change. But if I had only one thing that I would like to work on, we've heard that a number of organizations, even the Geneva Hospital, funders like Gates and Wellcome, governments as well, have policies requiring the sharing of data. But what we see is these policies are not audited or monitored or evaluated. And so if I had one thing I want to change is, if we're going to have journals with a requirement for data availability statements, then they need to be looked at and be part of the peer review system. And if we have research that's funded and includes a requirement to share the data, the funders take that seriously and monitor and evaluate the impact of that.
Thank you. And you, Naomi.
So just to echo what Rob said earlier, data sharing is not just about sharing the data, it's about reusing the data and then generating findings which can then be implemented in some way to improve the health of the public. So you need good quality data, you need appropriate analytical methods, and then you have reliable results. So the one thing I would change is to have more focus on defining indicators and outcome sets right from the study design stage, and then invest in training in data management and also in training in statistics and informatics.
Thank you, Naomi. Philippe?
So on the question of data quality, I think we could work collectively into the dissemination of standards. It's not to say that we will set in stone how people will collect their data, but there are common standards that could be used for many diseases. And we have participated at IDO with many stakeholders in each of the diseases in either the coordination or the makeup of a standard, the CDISC standard, for malaria, Ebola, COVID, Bichel leishmaniasis, and working soon on Chagas. And I think that's the way to go. We need to disseminate to the scientific community the standard to increase the quality and the way we are capturing information. But everybody thinks are doing the same, but they are not. On the side of data sharing, I think on an academic point of view, I think we need to have a proper metrics on the value of data being shared by an investigator, and that this credit is taking into consideration for the academic advancement. Without that shift in the metrics, we will not manage to just convince everybody to do so.
Thank you. Thank you. And you, Nathalie?
Yeah, I don't have the magic bullet. And the only one thing, there's too many things, but I think for researchers, seeing the win-win, in fact, aspect of data sharing, that there's value. If you share your data, you're also getting a lot from those that are sharing their data, and you're increasing the value of your own data as well. So I think, as you mentioned, the culture is very, very important, but respecting what investigators understand about this. And the other thing is having a system that facilitates this. It's not easy to share the data. So I think those would be the two things.
Yes, thank you. There are many things that are really connecting in your replies. Life must be easy for the researcher. It's already not so, in clinical research to stimulate our young generation to go into research and to spend time. We should not build new obstacles and new difficulties. So indeed, that's exactly what you have been saying. I have a question for you, Rob. We see that there are a growing number of repositories, probably even hundreds existing. Do we need even more, or should we go towards more standardization, more centralization?
Yeah, again, it's a good question, and I think there isn't a single answer. The biggest change that has actually happened, I think, for research and for many, for just about everything since the 1990s is the creation of the internet, which means we can distribute information for marginal cost globally instantaneously. So if we think about that, there isn't a need for centralization, there is a need for standardization, as Philippe has said. If everything is in a standard format, like a URL, then we can find it and use it and reuse it better. The problems here, of course, is once you get into complex data sets like clinical trials, you have many, many, many data points. So the discussion around what is the standard can be quite convoluted. But there are solutions out there. We've heard about CDISC, and there are many others, actually, that can be used. So my feeling would be, general repositories are good. So Zenodo, Figshare, Mendeley, these are extremely useful, should be used for data sets for where there is no real concerns around privacy and access and reuse. I think perhaps for other situations, and as I think as Nathalie has put forward a really good case, during certainly a pandemic where we're working in the dark on a new disease and we're having clinical trials, then the argument there definitely for standardization in protocols, and then perhaps bringing those together in one repository where everybody's following those standards, I think we can certainly see there would be massive benefits in that.
Yes, thank you. Indeed, Natalie, you gave an interview not long ago where you have this vision of a single or common repository at the time of pandemics.
Yeah, I think, you can't make decisions without being informed. I mean, that's the basis. So how are you getting information on ongoing research without having access to that research? So, of course, it's not simple. I think, there are discussions on how to be better prepared. There needs to be rules to govern this. It's not that, again, it's for everyone at any time of, any point of time. But I think the WHO, which is making recommendation, needs to have access to the best qualifying information to make those decisions. So here, as we are saying, in the case of pandemic, there are a few waivers that we're asking for in different circumstances. And I think for pandemic, there is a case to make here that we can save time, and time is the essence. As there's a report that says the 100 days report that is looking at having results within 100 days. You cannot achieve that if you don't have a system in place, of course, based on some governing rules, and you also need the funding. I think we should not forget that this has a cost. It's a significant cost to put this together, but it's what we need to invest in now. I think it's clear.
Thank you. Naomi, we know that there is a low usage of shared data. What practical intervention would accelerate reuse of data by researchers?
Yes, indeed. A few studies have reported that data reuse is significantly lower than what is expected. A lot of investment has been put in establishing repositories, but when the number of requests and actual number of outputs generated after reuse has been tracked, the numbers have been significantly lower. And we did a study where we were asking potential data users what is the greatest pain point if they want to use data. And overwhelmingly, they said that they couldn't find the data sets they needed. So they have an idea of what they want to do. They know what data they need, but they don't know where to find it. And that's because, in part, we've got lots of repositories and we've got data held behind walls. So people who are not actively involved in the research that generated that data actually aren't aware that these data sets exist. So I think the one thing that could really promote data reuse is increasing findability of the data. And that could be through, if repositories have standardized ways of describing what they hold, through using web technologies to harvest data from these different repositories and publish that in a common interface. So that makes it easier to know what is held individually in these places. And it could be easy to search and find if I want to know about a study done in West Africa on malaria in children under the age of 5, then you just need to enter that in a search criteria. There are some work going on around that. I think we need to push that even harder.
Thank you. Thank you for this very clear reply. Natalie, there are a lot of data protection rules in these repositories, and quite a lot of them are subject to interpretation. Is this a reality?
Yes, it's a reality. I think as I was saying, when you want to actually start sharing your data, you have to look at what you can share, and then you have to interpret what the rules are saying. So the rules are there to protect privacy of patients, and we have to respect that. But obviously, privacy of patients depends very much on the context. So, we are in the process of conducting a large study in Africa on COVID. And the way we addressed this was to ask PI. So we said, okay, let's look at the data from the CRF, all the data we're collecting from the CRF, and tell us, you, the PIs in your country, what do you think in those already pseudo-anonymized data, what needs to be further de-identified so that you can then share to other researchers so that there will be no risk of re-identifying a patient, because that's what the GDPR is about. And so it was quite a good exercise, because at the end, we decided that everything could be shared, except maybe one thing, which was the exact day of hospitalization for progression, because that in a country, in a specific hospital, might be an identifier that could, if someone was wanting to find that patient, allowing to do so. But I'm just giving this example to say, this means it needs to be done in the context, but it's not simple.
Thank you. Philippe, how do we develop a sustainable model, not only to support data platforms, not only for immediate sharing of data, but also let's imagine data sharing in 30 years from now?
That's a very good question, because we don't have the answer right now. If we look at the genomic world, they have put in place data bank, for lack of a better word, which are often supported by large consortium or international organization. But they did that about 30 years ago, when establishing international setup was very much welcome. In the current context, the geopolitical context where we are, we see a lot less appetite into an international new organization. So we need to invent something that doesn't quite exist right now. And it's really thinking of ahead of a data bank. So we need a commitment of funders, but funders usually commit for 5 years. That's really the bare maximum that we can think of. But we need to work and discuss with them of saying, okay, well, maybe there is a first 5 years, but there will be a need of probably more than that. And make the argument and the case that actually data bank are not only here for having data for sitting, for doing nothing, but back to the point that Naomi was making, for being reused. I'm going to share something that we should not get out of this room, and I'm sure you will keep it for you. But we have done or presented last week an individual patient data meta-analysis on the safety of artemisinin in the first trimester of pregnancy. And that's only because of that, because there were plenty of studies having been shared before, not having been published before, which were not bringing together the evidence for WHO to make a change of recommendation. That's only an IPD meta-analysis which is going to provide to WHO the evidence to make a new recommendation. So this is, this is not fantasy. And I think we need to take these case studies one by one and say to funders and to policymakers, this is to be used, and we know what we can do tomorrow. But there are things that we don't know, how we could use the data in 10 years, in 20 years, effectively, and we will stop there. Again, because we have been working a lot on malaria, primaquine is a drug which is now used for radical cure of vivax or actually elimination of P. falciparum malaria. This drug was developed in 1952. If we would have harvested the data on this drug during that time, we would have all the evidence needed to know that it's safe, probably, and how we should use it. Currently, we are re-engaging into doing clinical trial on this drug because we have lost the data. So, yet again, missed opportunity. We need to change that.
Yeah, these are two very concrete examples indeed. Rob, we know that there is an unequal capacity to manage and reuse data between countries. What can be done to ensure capacity is built and data is reused equitably?
Yeah. No, I mean, that's why one of the principles we put into this WHO guidance that we've just published is about equity. And that's because I've been probably working in data sharing the last 20, 25 years, starting with the Human Genome Project. And we definitely had those conversations there when we were sharing pathogen sequence, malaria sequence, and the malaria researchers there were saying, well, we've collected all this data, but all the publications seem to be appearing in Harvard and somewhere else. And there is a real sense that for many researchers, particularly in low and middle income countries, they are data exporters. The data is collected there. It can only be collected there if it's a disease that's linked to a particular environment. And so what can we do about that? Well, there's a number of things. So in TDR, we're very much focused on research training and building capacity. So we actually have fellowships that we provide people to go and work in EDO and go and work in pharmaceutical companies and in the PDPs to understand clinical trial procedures and how data is managed and curated. It's a very small drop in the ocean, but it's a step in the right direction. I think the other element which is bigger is in any data agreement, in any repository, anywhere in the world, there needs to be a consideration of equity between those that are depositing data and those that are reusing data. And that can be written into the data transfer agreement. We've done that a number of times within TDR and with WHO as well. And then that comes along with other things. And this is where we have to think about data as part of the whole ecosystem. And so one of the other things that needs to be put in place is an attribution for the data depositors, so they get some credit for that. And so the use of very specific URLs called a digital object identifier, a special little number, which can then be credited when somebody else is using those data. And then that then comes back to another point which Philippe said, which is, okay, how is that then used by universities and others to say, okay, your data has been used by 5 people, you need to get more credit for that. It's not just focusing on publications and citations. So there's a kind of ecosystem, there's a systems-based approach we need here. But in order to balance that, we always need to think about the equity of who is depositing the data and who reuses the data, and making sure that there's appropriate attribution on both sides.
Yes, thank you. And my last question goes to you, Naomi. It is hoped that through data sharing, there will be increased transparency in research through validation and verification of findings from other studies, perhaps even preventing scientific fraud. Is this a reality?
I'd say it certainly is a hope. I think we're headed there. We're not there yet. The fact that researchers at the beginning of the study know that their data is going to be used by individuals who weren't part of their study means that they need to put in thought into describing their data better, publishing their protocols, publishing their statistical analysis plans, and eventually publishing the data. So there's a level of awareness there that what you generate will be under scrutiny by someone else in the future. But on the other hand, I think it's a bit early to tell, because the policies and the mandates to share data are only recent, which means for studies that have been under that regime, they're just about getting published now. But what we have seen is, even though there are policies and mandates to share data, that actually is not happening, which means then that validation and verification of findings is limited. It's not as much as it would be. I'd give an example of during the pandemic period, we had quite a popular high-profile retraction of a publication which claimed that hydroxychloroquine was harmful if used for treatment of COVID-19. And the effect of that was a couple of studies which were studying this drug were actually paused, and others were actually completely stopped. But later it was found that the data on which this publication was funded was not credible, and it resulted into the publication getting retracted. But what is interesting is the researchers could not provide that data set to support the publication, and that goes to show that the transparency isn't there yet, but I'm hoping that it's something that can be developed in the future.
Okay. Thank you. Thank you very much. Now we are entering into the third chapter of this session, and really return ourselves towards the audience. Hopefully you will get out of the shade. I'm sure that some of you, perhaps many of you, have questions to our experts or comments, experiences to share. Yes, please.
Sorry, hi, Naomi, I wanted to bounce on that comment you just made with regards to the surgosphere. I believe it was The Lancet that published that study. Is it envisageable, sorry, how do you say that in French, in English? Is it plausible to imagine that the journals themselves have a certain responsibility for whatever they publish, and hence there is a penalty for publishing data which is known to be fraudulent, or they find out to be fraudulent, because it was a peer-reviewed journal. And as you said, it resulted in pausing studies which were never restarted afterwards when they found out the data was fraudulent. Is that something that could be possible for data, like a data regulatory penalty?
Yes, please, now.
I think the journals definitely do have a responsibility there in making sure that publications which are put out in print have been peer-reviewed, and this data is available to the reviewers, and is also available to the research community should there be a need to verify the findings. That obviously did not happen in this case, and actually the reviewers did cite that there were difficulties in accessing that data, and the researchers claimed that they could not provide the data because that would breach their privacy and contractual agreements which there were with the clients. So yes, there is definitely a responsibility by the journals, and with regard to a penalty, yeah, absolutely, because the whole purpose of research is you want to trust science and you want to believe that what's being generated can be used to inform policy. So if you don't trust the science, then there is a problem.
Someone would like to complete? No, I think your reply was clear enough. Thank you. Yes?
My question is, you have described very well the tension that we have between data protection and data sharing. I would like to have your opinion on how can we solve this tension, especially when we are talking about either epidemiology or baseline data on clinical trials.
Philippe, would you like to?
I can try. So, yeah, we've got to protect the privacy of the patient, and we need to allow data sharing for the benefit that we have sort of tried to describe. That's not impossible, first. Let's not start with there is no solution and then we are blocked. Let's start with the contrary. There are solutions and we need to work collectively towards these solutions. So first of all, open science doesn't mean that it's a click on a button and then you download the data and you run away with that. I think it's clear that data sharing can be done in a certain, in the context of human research, in my opinion, should be done in a controlled environment. And what does that mean is that the data are deposited somewhere. The person or the groups which has an intention to use these data would have to describe what they want to do with that, present credentials on their capacity of analyze the data, and then essentially get access to these data. So this should not be a blocker, but they get access to this data for the purpose that they have requested the data for. And then this is a binding agreement that they have in between the repository and the data requester. Meaning that if they try to re-identify the patient, there is no such a thing like zero risk. So there will be always a risk that re-identification could be made. It's a question of measuring that risk, but I think if we are in a control framework where we clearly say you have an obligation to use the data only for what you have asked the data for, and if you breach that agreement, then you are penally, you would have to respond to that. I think that's the way to address data protection in a responsible manner, and not blocking data sharing, but allowing data sharing to be done in an equitable way.
Yes, Nathalie, you would like to complete?
I'd like to contradict a bit, not contradict, but comment a bit on what Philippe said, because I fully agree, of course, with everything you said, except that you're assuming that the database is already there. But what we have learned is that for the data to be allowed to be shared, there is an intermediate step, which is maybe the one Olaf is referring to, which is the new de-identification. And I think we have, again, a tension. I don't know, where we are, but it's not as if you can put your data in a database and then you have controlled access, and that would be easy. Unfortunately, what we hear is that before doing that, you have to work on the data, not to standardize, but to remove what is perceived as breaching data privacy. And this is where maybe we need to get a bit more guidance and clarity of how to do this in a way that doesn't become the obstacle that we're referring to. And it is not simple. That's why I was mentioning maybe contextualize, but we need a bit more guidance, because otherwise we will spend a lot of time to trying to interpret the law to be abiding by the law, but no, not necessarily in the best interest for all.
Naomi?
Well, we've just produced this guide, and there is a lot of these solutions are technical, and there are very good technical solutions for creating data that's anonymized to a statistical power of more than 92% and using the safe harbor principles and all of those types of things. And I think they can be done, and we can show you how to do that. The real issue, actually, I feel, and it is one that you mentioned, Natalie, it's around trust. And I think it's the trust in the public, but it's also the trust in the researchers themselves. And there's been a bit of a tweak recently where researchers are now feeling, if I fall foul of these laws, am I going to get into serious trouble?
Right.
And therefore, the default position, if you're ever in that situation, is do nothing. It's always easy to do nothing. So I think that's the real barrier we've got to try and overcome, is to make the equitable and safe and effective sharing of data the norm, and people feel confident to do it, and then the reuse is rewarded. And if, you are the public, I'm the public, we should be demanding that this is happening. Because for a large part, more than 50% of research generally around the world is funded with public money. And if it's not being reused and reused, then it's being wasted. And so, we should be demanding that. But building that trust is a tricky situation. I don't know if there are any more questions. If I can remember, about 20 years ago, we were building a 500,000 cohort population study in the UK to link environmental factors and genetics. And so we did lots and lots of workshops explaining to people how we were going to use their data, what it was going to be used for, and everything. And we did hundreds of these at the weekends, and people, I would say 90% of people, once they had access to how things were being used, were very comfortable and very happy. And I think so that's how we kind of build that trust, that openness. There was one situation, I remember one gentleman at the end of the day said, "Thank you so much, I've learnt a lot. I feel this is a really good study going forward. I don't want to sign up to it, but I'm very happy if my wife does."
We do have 3 minutes left, so maybe just one last question before we wrap up.
Okay. I don't want to frustrate Naomi. Would you like to have one more thing in this reply?
Thank you, Francois. Data sharing has been going on for as long as research has been conducted. And just to echo what Rob is saying, these data protection laws are actually a new thing, sort of relatively new thing, that is coming in as an intermediary step before you share data. But data sharing has been going on forever. And if you would like, for example, to map out, to do some geospatial analysis and map that alongside some sort of disease, you would need a lot of data sets. And if you have to go through data access committees and applying for those data sets, if eventually you're not going to be able to do that research. So I think there's a real strong need to rationalize data protection laws and then contextualize them and make sure that they're not working against the public that they're meant to be protecting.
Time for last question.
There is no more time, unfortunately.
Oh, no, you said 3 minutes. It's only 30 seconds ago.
I've just been told that it's time to wrap up.
So,
The last minute approaches.
I have to give up. Anyway, maybe after the session, if you have questions or things you would like to discuss with our panelists, they will be around. Well, how can I conclude? This is, it's not a new field, but for many of us, it looks like a new field that evolves with these technical, these ethical, these legal issues, etc. Let's do everything that can be done to keep all this process simple and straightforward so that it can be applied widely and adopted widely. And there is this trust word that has been said many times in this last hour. So thank you so much to to you, the 4 panelists. Thank you to the audience as well. And I wish you a very good evening here in Geneva.
Thank you so much, Francois. Thank you to